All right, good afternoon, everyone. Thank you for joining us today. My name is Cynthia Klein, and I serve as the project director for the Take Heart initiative. On behalf of our full team, I'd like to welcome you to today's session. We'll be focusing on preparing for and understanding your data to support systems change. We have some excellent speakers on tap for you today. We are joined by Professor Sherry Grace, as well as Matt Thomas, who will have a lot of information and lessons learned to share with you on this topic. As we get started, let me remind you that today's presentation is the fourth in a series of 10 training modules. So these training modules are designed to provide implementation support and also share best practices with Take Heart hospitals, implementing automatic referral and care coordination. All of our training modules are guided by the roadmap that's been established by the Million Hearts Cardiac Rehab Change Package. This change package is located within the Resource Center that's on the Take Heart website. As a reminder, actually all of our educational materials and resources, including the training session recordings, can be found within the Resource Center of the Take Heart website. Now, the format of these training sessions, they include a presentation by subject matter experts, coupled with the opportunity to interact through the chat and the polling features that are available within this webinar. And these enable you to dialogue with other hospital participants and allow you to have some of that peer-to-peer sharing. Following today's session, you'll receive guidance materials in the form of an implementation guide, and that'll help to reinforce and supplement the material presented during today's training session. And then even after that, technical assistance will follow with the partner hospital peer action groups. The peer action groups meet with their assigned coaches to discuss the concepts that are presented today, and also provide updates on their progress, their successes, their challenges within the project. So the peer action groups also offer you as participating hospitals that opportunity to share and offer support to other hospitals in the group. Please remember, you can also reach out at any time to your coaches between meetings for questions or concerns as well. So going to the next slide, we don't intend for this to be a didactic training at all. We would really like to hear from you. And one of the ways that we do that is through the chat function. So at the bottom of your screen, if you're not familiar with it, you'll see a conversation bubble that's similar to the one that's shown up here on the slide. Click on that bubble and it'll open up the chat box. If you can also set the chat to field to everyone, this will ensure that we can see all of your questions. We do ask, if we had one request, it would be to keep the questions general in nature and not hospital specific so that the entire audience can benefit. We may not get to all of your questions today, but we will respond to unanswered questions after today's event. Go ahead and feel free to type in your questions in the chat box at any time during the presentation. And then one last reminder, as with all of the training modules presented under Take Heart, we do have CEUs available for participants to attend the live sessions, and some information about claiming these CEUs. We'll send that out to you within the next few days. All right, with those reminders, let me go ahead and pass you off to Steve Hines, who's going to help moderate today's discussion. Steve?
All right, good afternoon, everyone, and welcome to what I'm really excited about. Data is so foundational. We've got great panelists, we've got a great topic, and I'm sure that this is going to be a great next hour. So we thank you for joining us. As a reminder, just to contextualize where we are, this is a part of the Take Heart initiative, and to get where we need to be at the end, we started with 2 modules that were just an overview of the case for automatic referral and effective care coordination. And we introduced you to the concepts of system change. And then in module 3, we talked about workflow processes and how you could map your processes to understand where your referral processes or care coordination processes might benefit from improvements that you can be working on over the course of the Take Heart initiative. So those lead us up to module 4, which is our focus today, which is on data. And as a reminder, we asked all of the participating hospitals to complete a data planning exercise. And one of the things that we asked them is to identify which types of data they had accessible to them. And if you look at the list here, you'll see that there's a big range between the percentage of participating hospitals that had information on things like time between referral and enrollment, and whether each eligible patient has been referred to yours or another cardiac rehab program. Those were only held by about a third of the participating hospitals. On the other hand, around 2/3 of the hospitals had information on basic patient demographics, contact information, as well as the number and timing of the cardiac rehab sessions that patients have participated in. So what this means to us as we go into today's discussion is that we recognize that there are going to be hospitals on this call that really don't have a whole lot going yet in terms of data. And that's fine. You're here because you want to improve that, and we respect that. On the other hand, some of you are a lot further advanced than your peers. We encourage you to share your insights about how all of this works, to share what you've learned in the process, to commiserate, and importantly, just to reinforce to everyone that the difference between being far along and not far along is really a matter of how much work and how much time you spend on this. So everyone can get to where our most advanced hospitals are. It's just going to take time, and the insights of the that you'll receive in the presentations today, as well as in the other resources that we'll be providing for you. As far as our learning goals for today's session, there are three. We want you to understand the importance of data and identify different types of data that are directly relevant to the Take Heart initiative and your efforts to improve care coordination and implement automatic referral. We want to help you be able to understand how to establish baseline data for referrals, enrollment, adherence in cardiac rehab. And then we also want you to think through a plan for you to collect and measure and monitor performance of changes specific to Take Heart. We think that having a plan will help you get further than you would if you didn't have a plan. We also think that you're likely to change that plan as time goes by. That's perfectly normal, and really it's a good thing because it shows that you're adapting to things that you're learning along the way. So those are the learning goals for today's session, and I'm really delighted to introduce the panelists for today. Professor Sherry Grace holds her primary appointment as a full professor in the Faculty of Health at York University up in Canada. And Grace's research center focuses on optimizing post-acute cardiovascular care globally, as well as patient outcomes. And she's led the development of Canadian quality indicators for cardiac rehab, as well as policy positions on systematic referral and utilization promotion. And she's got a wealth of insight related to the practical nuts and bolts of what it takes to really learn from your data and to enhance patient care as a result. And then we also have Matt Thomas, who's the director of cardiopulmonary the cardiopulmonary rehab program at Chi Memorial in Chattanooga, Tennessee. Matt is a master's prepared clinical exercise physiologist, and he also holds an MBA in healthcare administration. He's an active advocate for cardiopulmonary rehabilitation and a clinical exercise physiologist serving on AACVPR's MAC task force, as well as the Clinical Exercise Physiology Association's Legislative Committee and ACSM's Exercise Medicine's Older Adult Committee. And his current research interests around the novel delivery of stress management. Hopefully we won't put that too much to the test today, as well as psychosocial interventions in cardiopulmonary rehab, in the cardiopulmonary rehab setting. So two great speakers. I'm delighted. I've learned a lot in our initial conversations with them, and I think I'm going to turn it over to Professor Grace now, and Professor Grace, do you want to take it from here, or that would be great.
Yeah, so thanks so much, Steve, and it's a pleasure to be here with everyone. So data can be a bit daunting, so I think we're here to help everyone keep it in perspective and see the great value of using the data that you do have available. So it's very important to us because in quality improvement, it really helps us assess where we are at to start with. And then from there, we can see the gaps, any errors in the data, any discrepancies between where we are, where we want to go. And then it really enables you to set kind of realistic targets about where you want to go to over time. For the Take Heart project specifically, we're using data to implement a workable automatic referral system for inpatients, exploiting EMR, and as well as this care coordination, so promoting our patients and enrolling, adhering, and completing programs. So data helps to establish the need for the Take Heart project, so you can communicate that to your stakeholders. You can say, hey, this is where we need to be, and this is where we are today. You talked about your workflow process improvements last module. So this helps you kind of see where you're at in relation to those and where you want to go. It helps you monitor your progress. So as you move along, and it helps you ensure that as you change, that you can sustain it over time. And it's really difficult to refute if you have data. Those on your team, those stakeholders, hospital leadership, are really going to listen, and it's going to be compelling to them. So there are kind of different ways that you can use data. When you get data from a patient chart, which you'll be doing from an individual patient, you could look at things like diagnosis or their indication, did they have a CABG? Why are we sending them to rehab? What's their age? What's their sex? Where do they live? What is their rehab use? So we can get all that at the patient level, and that helps us tell some things. But then also, if we aggregate it, we can look at kind of overall measures or indicators of how we're doing. We can generate reports to look at. So, overall, get a sense of in your population of patients who should go to rehab, how many of them are eligible? Of those, how many are referred? How many enroll? We can also look at underrepresented groups with some of that patient level data that you gathered. So here are some kind of examples of how you can use the data if you have the patient level or this aggregate data. So at the patient level, you can kind of look closely at, which patient, why was that patient not referred, for example, or, is that patient from an underrepresented group, and so maybe we're not engaging them as we could, or are there certain providers that don't seem to refer? Maybe you can talk to that provider about a reason, that they might not have when you don't see one. But at the aggregate level, you can take a look at your workflow processes overall. You can take a look at the proportion of patients that you're actually getting in relation to your target, etc. So last time, you've also kind of got a sense of the team that you need. And so again, we want to gather all those people around to work with you and make you successful. So definitely you need the acute care team. So we're, referring from that inpatient unit, but you also need the rehab program, right? So you have the full continuum of care. You're going to engage the clinical and the non-clinical staff involved in the referrals and the care coordination, right? You need to know what patients we're trying to get. And then you're going to have your partners in kind of IT, billing, coding, who, really have a lot of the data and help you understand the data, access the data, and hopefully you might have quality improvement representatives at your institution or data analytics even, who can help you around kind of the process improvements and visualizing the data and tracking, etc. So the goal here is to collect your baseline data. So for the automatic referral piece, right? So we first need to know where we're starting from. So before we make any changes, we need to know this is where I am. And so basically you want to get a sense of, from your institution in your inpatient unit, how many eligible patients are there? So what is your pool, right? And then of those, how many have been referred? Look at diagnosis. You can look at the providers, right? Are the surgeons referring the same degree as the interventionists, for example? Take a look at the sociodemographics as well. From a care coordination perspective, you can also take a look at some important baseline matters, such as how many patients enrolled, where were they from, looking at their zip code, are they in your area, are they not, were they contacted by a care coordinator, what were their demographics. So your key first step here is, again, to look at that workflow process that you created last month. Use the data planning tool that was provided to you, and then you can work together with this team to gather your baseline data. And I'm going to pass it to Matt now, who will give us some examples on how he did this.
Yeah, thank you, Professor Grace. So, Professor Grace has gone through a lot already of different reports that you can set up and that you can potentially use. And I think one thing that we all need to remember is that our data is going to be unique to our center. So if we think a little bit about how we set our baseline, we need to recognize that this is going to be, in large part, an individualized process. What are your current needs? And I think a good place to start with the baselines, and at least this is how I typically approach it, is to first start with what are your expectations. And what I mean by that is, what do you expect to see in any particular value? So do you expect that you have a good conversion rate? Do you think that it's high? Well, expecting that to be true, and conversion, of course, I mean, getting your referrals and turning them into participation. You can expect that it's good, expect that it's high, but that's not always the case. So turning it into the observed is very different. And that's where data comes in. The baselines become really very important because, as Professor Grace already pointed out, this is how you show value to your team, to yourself, to your patients, your administration, etc. It really becomes the objective measure by which you're able to perform, set action plans, and move forward. So it is certainly worth your time. So you have to start by discovering your baseline. And as I'm kind of pointing out, you have to first decide what's the most important thing for you to look at. So here's some examples, right? And these are just kind of things that we look at typically in our centers, things that we track routinely. One of the reports that Professor Grace mentioned was your referral source report. Well, this tells you a lot about who your main providers are, who your referral sources are. Are they coming from inpatient settings, outpatient settings? Are they from your surgeon, your surgical team, your interventional cardiologist, maybe your non-interventionals? And being able to discover who those providers are and how they're referring tells you a lot about how to leverage your successes and also be able to identify the areas where you're deficient. And I think really with the baseline information, the main thing I typically look for, and not that I'm trying to celebrate our shortcomings or failures in our department, but it provides opportunity. When you have that baseline set, you know what's abnormal, you know what is off of the mark, and I think that this is a good analogy for our cardiac rehab world. It's how we do EKG each and every day, right? We start by knowing what the baseline is and what is normal sinus rhythm. If something's different from there, we start to ask those standard questions of why. We can get analytical. The same is true with all of our data metrics. Once we know our baseline, we can start to move through some systematic questions that are going to be able to move us forward on a good action plan as we interpret the data. So looking at your referral sources, looking at your referral profile, for example, let's say that you have 10 cardiologists, but you go through and start to look at your data and realize only 3 or 4 of them are referring. Well, that provides you some opportunity and you can start to set an action plan in place. Baselines can help you identify who your main primary participant is. This is some real life data I pulled for this talk. We know from multiple cross-sectional analyses over several years of operation that our standardized patient is a 68-year-old Caucasian male with a history of an open heart or a CABG. That isn't necessarily just so that we can know who our patient profile is. It's so that we can see now who are our uncommon participations. How can we reach out to them? How can we leverage those successes again, but identify those areas that we're deficient? So once you set your baselines, you really want to spend some time asking some analytical questions. Analyzing the reports, asking the questions is a big piece. And I think a big part of this is if we're talking about the expected versus the observed, right? make sure that it's not just your own expectations. Bring those expectations to your team. Our own expectations certainly can provide some bias. So if you look at the expected numbers or values and you talk to your team about that, see if they match up. Now, once you get your observed data, really bring it back. And if the observed is vastly different, now you can start to ask some questions. Why? Do you have good methods of collecting data? Is there a potential source of data that you're missing? Are you over-reporting? Are you entering bias because you want things to be successful? Those sorts of things. So just make sure that your expectations are also meeting your teams. And in valuable settings like this, where you're able to interact with your peer, do your best to benchmark against other sites so that you can really kind of check the reality, so to speak. And Professor Grace is going to take us through a few other baseline considerations.
That was really helpful. Thanks, Matt. Thanks for sharing. So yeah, we've got now this baseline data. Now we want to manage all these eligible patients, track them along, measure what's going on as we implement our workflow process changes. So what do we need to think about? We need to think about, our new processes required. What is your plan for the increase in referrals that you're going to get? So at the rehab program, how are you going to absorb these extra referrals without expanding your wait time? What additional resources are required? What software do you need? Who's going to handle the monitoring and the reporting? How are you going to fill those roles? And then what about missing data, right? So, and you can't get everything that you need at once, but what the most important pieces are for you and your team. There's going to be some missing. Can you get that? When will you do this, right? So getting everybody on side for kind of when it's going to get started, and that's kind of one of the keys to success. So once we have, again, this baseline and we have this plan to track everybody, we really want to see the change and take a look at what our actions and our workflow changes, what happens as a result. So this helps us kind of inform decisions over time. It helps the team understand kind of what's working based on what you're doing, what are the impacts of your efforts. And then you can communicate that through your organization, and that can continually drive more improvement and more improvement. And that really also maintains accountability, and it helps with sustainability too. So let's now take a look at a couple tangible measures, and you will recognize these from AACVPR. So a measure generally has a numerator and a denominator, so we're just doing some simple division. You can do this in Excel, for example, if we want to keep things simple. But for the automatic referral piece, the most important measure is the percentage of patients referred. So your numerator generally is the number of eligible inpatients referred. And the denominator would be the number of inpatients discharged with the codes, the ICD-10 codes. And again, those are all listed in the materials in the implementation guide. And are well established based on evidence. I would say you might want to consider some exclusions and kind of talk about those with your team ahead of time, so everyone's on the same page, because they can vary based on your program and your institution. So we did a consensus process internationally, and some of the exclusions that we consider to be valid are things like advanced terminal illness. So maybe a cancer patient in palliation, some sensory impairments. So, maybe extremely low vision, serious mental illness. So I wouldn't say, depressive symptoms, anxiety symptoms, those are very common and those are ameliorated in rehab, as we know. But patients that, for example, have uncontrolled schizophrenia or, substance dependence, that's going to impact their ability to participate. So those are some kind of valid exclusions, and again, talking maybe to the inpatient referring providers about those, and again, getting consensus would be helpful. But again, then you have to be able to kind of think about how you'll capture those, or maybe you can even capture, are any of those exclusions applicable to this patient, yes or no, if you can't get that sophisticated yet about measuring some of these specifics. But again, I think it's important to have a dialogue, because this is a pretty important measure. And then when we look at care coordination, enrollment is the main indicator or measure there. And by enrollment, we mean generally attending a first visit at the rehab program. So here the numerator would be the number of referred inpatients that came to that first visit. And then the denominator would be the number of inpatient referrals you have. So again, here just focusing on the inpatients only. You don't want to maybe include any external referrals to keep things clean. And here, again, you might have some exclusions that you might want to get consensus on in advance. This might be things such as, you know, a patient says, hey, wait a minute, I'm going out of the country. I'm going to start, can I start in 6 months, right? And if you notice here in the top right, we're suggesting start perhaps with a monthly measure. You can, again, tailor this to your program and your needs. But if you're doing that on a monthly basis, you do maybe want to leave out patients who, or maybe they live in another country and they're not coming back, or maybe they say, you know, I literally do not have any transportation to get there. And, you know, you don't offer a virtual program. So again, talk about some of those. And again, this will be one of your main indicators of care coordination. There are a few other measures.
Professor Grace, before you
Yeah.
move on, I just think it would be helpful for the audience to know, as you were like working with the cardiologist to build consensus around those exclusion criteria, how long did that process take? I don't want anyone to think that they can do this over a weekend, but on the other hand, I don't want to think that it's going to take forever either. So could you just talk a little bit about how long that took for you to do?
Yeah, so certainly. So I think we did it as a kind of a research community, and I can share that with participants afterwards. Kind of we have like a Delphi process and kind of came to an agreement, because sometimes I think that inpatient physicians think some things should be exclusions when they aren't really valid exclusions, because they don't know maybe as well what we do manage in rehab and all the different elements of what we offer and how it helps patients. So I think even just having the dialogue is good, because I think you'll circumvent them not referring patients that would be really good candidates. I think that's kind of the benefit of it, is having that dialogue. And again, if we kind of use this evidence around, you know, there's an international consensus that, you know, these are valid exclusions, but these ones maybe not so much. And then just I think it's more of a dialogue, and it doesn't need to be you know, too difficult or onerous for as part of the process.
Thanks.
Yeah, no problem, Steve. So a couple other, I mean, if you want to measure other elements too, on the next slide, we'll see a few more for the referral piece. You might want to measure wait time. So the number of business days from the referral being received at rehab to that patient attending their first visit. And I think sometimes we actually see that wait time going up as we refer more, right? So it is nice to watch this along with your workflow process improvements, because sometimes you can see these unintended consequences and just want to keep an eye on those. The other thing, as we were just talking about, is like looking at some of these exclusion reasons. Are they valid? And then, you know, do you need to maybe tweak your EMR referral system to better deal with this, so that it's easy for everybody and everybody's on board? With regard to the care coordination piece, you might want to also measure the number of patients that have a visit or an interaction with the CR care coordinator, right? So did that interaction happen? And also looking at the patient adherence. We get them in the door. You would prescribe 36 sessions generally. You know, what percentage of those sessions did they attend? Did they go and complete or come to the post-program assessment? So with that, we have a few tips for success here. You know, we can't do it all at once, as Steve mentioned at the beginning. So start small and just expand over time. You want to keep your data collection really simple. You want to think about your highest priority changes, you know, based on that baseline data, as Matt was showing you. You know, think about what is the most important for your center. Measure frequently. So we're thinking, you know, generally a month at a time is nice, and you can see change that way. Discuss with the team that's working with you. What progress are you making? What success are you making? But then again, there will be some areas where you want to make some improvements, revisit some things, and adjust and try again. So let's pass it over to Matt for some more stories from the field.
Yeah, thank you. So I think we tend to approach data sometimes in the wrong way, and we have the misconception that, well, I'm not going to collect particular variables because I'm into patient care. That's why I entered this field in the first place. Data is for my informatics teams and administrators and people who spend all their time in the offices. So it really doesn't resonate with me. It's not something that I have to pay attention to. But I kind of developed this little case study just to show us that data should be part of evaluating and improving our operations all the time. There are times that change is going to happen and we have to react to it. And so again, as I kind of pointed out in the first part of setting those baselines, is that do our expectations meet what we're actually observing? Does the shoe fit, so to speak? So here's a scenario for us to discuss and kind of consider as we look at, and not totally exhausting this subject, but how we would respond to some scenarios that are more than likely in our centers, especially as our programs continue to grow in response to just kind of the trends in the United States right now. So your hospital's cardiology clinic has been given approval to design and open a heart failure clinic in the coming year. Your program's medical director has excitingly told you that they anticipate the heart failure referrals are going to increase, and you're going to have the opportunity to get referrals from the community, so primary care providers rather than just your typical inpatient pathways. So in preparation for this, your service line administrator has asked you to set up an action plan on how your cardiac rehab program is going to be able to accommodate what you anticipate to be a growth opportunity. So here we have it, just perfect scenario, falls in your lap. Your cardiology service line is growing. The downstream is going to fall into cardiac rehab. What are you going to do next? So let's look a little bit about at this case study and see in what we find when we examine the data. So we've picked our variables. We have looked at, what we expect to be our main baselines, what we think we know, what we expect, and we even dial it down and look at what we observed. So in examining our data, we've seen that heart failure diagnoses at present only make up about 15% of our total referrals. Heart failure participation is low. So of those 15% referrals, they only account for about 2% of our total phase 2 volumes. Heart failure patients are primarily being referred through an inpatient pathway. Heart failure patients, when they come to our centers, are staying for about 28 sessions on average. As you continue to look, we see that the breakdown of referring physicians shows that only 4 out of 9 of our providers or eligible providers are ordering cardiac rehab for these patients. There's no automatic referral process set up for this inpatient pathway, and you see that your current phase 2 program is operating at 65% of its potential capacity based on tangible resources like your staff, space, telemetry, etc. So a lot to digest here. We could probably spend the rest of the hour looking at every one of these variables and how we would inevitably set up an action plan to improve it. But the whole point of this case study is just to point out that when we pause and we look at some very basic data points, see what we actually observe based on our expectations, we can set up action plans that are really going to improve our services. They're going to improve it in terms of high quality. It's going to in terms of patient expectation. So in a couple of these, I think we look at the opportunities here. If we just think about if we were to focus on an automatic referral process, whether that be for our main primary care providers in network to refer these heart failure patients, or just in the inpatient setting where it's already lacking, you're going to have a powerful impact on some of these observed metrics. For example, you would expect to see an increase in total number of referrals, right? So you're casting a wider net. Therefore, you're going to have a better, whatever your conversions rates is, even if it does not change, your participation will go up. Your breakdown of the referral physicians, I think, is a big one. Automatic referral brings the capacity of maybe only 4 to 9 we're referring. Well, you have an automatic referral process now. It's a standing order. 9 out of 9 are going to refer. So you're really going to see big impacts on your operations. But imagine if you approach this case study based solely on your expectations. So if you just went off of your gut feeling that, oh, well, that we are going to have more referrals, so we better bring on more staff, we better get more equipment, we better, et cetera, et cetera. The expectations can be misleading because as we looked and we observed, we found that we're operating at only 65% of our capacity. So now we can really be making some intelligent decisions that really hit the bottom line on our total operations. So in the opportunities, in this particular case, automatic referral really stands to be one of our biggest impact metrics, especially, if we consider where we're operating already. So as we continue to look at this situation, this case study, we just want to think a little bit about the workflow because there are some standards out there on how we move through a process to observe these things. And like I said, and I certainly recognize that these metrics may be more alive for some centers than the others, but if we kind of make this expectation versus observed application, we need to think about what we do in a process, and we can move to the next slide, that really is efficient, right? So the first thing we have to do is identify who our stakeholders are. Who is going to be most impacted by these changes? Well, we have some primary care providers that are now going to be able to refer. We're going to have a heart failure clinic. We're going to be seeing a whole new demographic of patients. So here's some opportunity to reach out to those individuals. The estimates of our volumes, this is where that expectation, the expected versus the observed, is really going to be big. If we simply expect that volumes are going to increase and we don't know what our baselines are, how will we respond to that appropriately? So analyzing the impacts on our current operations in this scenario is an imperative. Even if we don't find ourselves to be formally trained in statistics, data gathering, etc., we've got to do it in order to respond to a changing climate. So think about here as we analyze those impacts on our operations, what are our tangibles? What are the resources that might be overburdened with large changes? So really, this is kind of about taking stock of the variables that you can't or cannot change just as much as there are the ones that you can. And as you analyze, that moves down the line. So you have to think about staffing, other resources, expendables, things that hit the bottom line, so to speak. And then determining the quality data metrics. So this is an opportunity, and as we've pointed out, data collection is a moving target. It's going to be changing all of the time. Well, if you have a new heart failure clinic, a new demographic of patients, you're going to have to determine new quality metrics. So new benchmarks are going to be set. As you set those baselines, you're going to be looking at year-to-year variables, month-to-month, making comparison, and really setting the validity of your operations going forward. And I think Professor Grace is going to talk to us a little bit about how we can monitor those things and track them.
Yeah, absolutely. So I wanted to start by talking a little bit about established ways to measure these quality metrics too. So if anyone is at an institution where they're participating in in an ACC registry through NCDR, so the chest MI registry, chest pain MI, for example, they track referrals in there. You could exploit that and leverage that. If you're part of the AACDPR registry, for example, they track enrollment, participation, completions. You can really use that as well. You can also think about, as we've been talking about which providers are referring and what's kind of happening based on the logic behind how your automatic referral is set up in the system. And again, I think you're going to talk a little bit more about that next month. But you can see, which providers are referring. Do you need to make some adjustments in there as you can begin tracking this over time? And really, when we do that, we want to visualize that. So you could maybe use a dashboard or some kind of format like that to track your monthly numbers over time. So on the next slide, we talk about the importance of data visualization, or kind of graphically and visually representing the data that you have so that it's easier to interpret and so that you can share it with the other stakeholders and everyone kind of, gets on board about where you're going and how well you're doing and what needs to happen. So it really renders the data more easy to understand for all the parties involved. There are really quite a few different ways you can do this. I mentioned dashboards before. That might require, collaborating with your IT team, and maybe not all of you have that, but if you do have data analytics folks they're really handy at this and can whip something really lovely up for you. And the implementation guide has some really nice examples that you could work from there. But Matt here is now going to show us some examples of different charts, tables, graphs, timelines that you can use to see the impact of your workflow process changes over time.
Yeah, absolutely. Thank you. So I think on the point where I'm trying to really drive home is that don't let the data be too daunting, is recognize that there are formal, less formal, and probably a lot of technologies already at your fingertips to make your baselines attainable. Bring on visualization and really make some impact statements to your primary stakeholders to drive change. Professor Grace already pointed out some of those more formal opportunities, things like existing registries with the AACVPR registry being a great dashboard that's already set up. And I'm really a huge advocate of that. They've done a nice job making it easy to enter the data and pretty much foolproof. But maybe you don't have the financial stability or opportunity to invest in and participate in those registries. Well, there are still options. The first thing I would say is reach out to your service line, move up the chain, even talk to the primary cardiology clinics that are referring to your centers and see what quality initiatives or registries that they are already participating in. You will probably be surprised to find that many of these QI initiatives require them to refer to cardiac rehab or meet standards and metrics that you may not have been aware of. Some of these things may already be in place and be as easy as a conversation with those stakeholders and those referral providers going forward. But beyond that, if you have access to a workstation, whether it's Microsoft Excel or it's Google Office, there are a lot of tangible and easy to use tools that you can bring on. If I can make one plug for the use of Microsoft Excel, it is to enable one particular add-on, and it's on your screen, and that's your data analytics tool pack. You can Google how to add that, but it's very easy to add. It doesn't come standard on Excel, but this gives you the ability to break down your descriptive statistics, so your means, your medians, and do it all very quickly. I recognize that not all programs, actually I would say very few, probably have resources available for individuals to sit and do data all day. Many of us are out on the floor working off of those expectations and trying to respond. So we need to find efficient tools that allow us to see and visualize the data. It becomes very powerful. The next step for that is not only visualizing it ourselves so that we can respond and build action plans intelligently, but also so that we can motivate our staff and allow them to see where we're going and what the trends are. The third step for that is being able to take information back to our providers. So these graphs, these charts, they shouldn't just be a fancy or pretty way of putting your data. It's a means of concisely depicting what's happening in your space so you can very quickly put it in front of one of your medical directors, your providers, show them what's going on at a glance, and they can be able to help you make some plans going forward. The final piece I would point out in your tracking metrics, we've talked about a few, but a lot of the EMRs are set up to help you and probably already are tracking some of the data. Again, it's talking to your informatics teams, some of those specialists that work with that every day, and asking them, challenging them to see what reports are available before you go and build something from the ground up. My saying with Microsoft Excel is you kind of have to pay to play, right? So I'll spend hours building a new spreadsheet before it gets to the point where I can plug the data and actually get something meaningful from it. Once it's built, it's very easy to use, but you might be surprised to find what's already out there with some of our existing EMRs, whether it's Meditech, Epic, or the like. So look at what your work queues offer you. See what revenue reports are out there, productivity reports. They can be very telling on what's going on in your spaces. And the final thing I would say about that, and I love that tip sheet. I think if there's one thing everybody takes away, it's the tip sheet we went through, is keep things simple. Make sure your data is simple to collect. So long as it's reliable and it's giving you some good information, you can work to refine those things later. So I'm going to show you a couple examples of some real life things that I have going on right now, just to kind of put this into perspective. So one initiative that our service line saw a deficiency in this year was our PAD referrals for our PADSET program. We had just started our PADSET program last year, and as I started looking at our referrals, I thought, goodness, these are really low volumes. So we went before our team, talked to our vascular surgeons and our cardiologists, interventional cardiologists, and I just brought this to them. And they actually set a co-management goal where they held themselves to making sure that they were participating in an automatic referral process. And so we just started tracking the data very simply. So this is a report that I give to them once a month. I drop it in an email. They're able to see at a glance if we're hitting the mark for the goal that we set for ourselves or not. So what I expected, right, was much higher than what I observed. So we made an action plan. So from there, you can see that this shows month-to-month data and trends. From the time that we started this initiative in February, I just very simply tracked the total number of individuals that were coming through. We looked at how many referrals we were getting, how many of those referrals enrolled, i.e. our conversion or participations, how many of those patients declined. You can see in this next column with those that referred out, that means how many people started going out of our system. We didn't start tracking that initially, so I only have one data point for June. That's some evidence to show you that you might start looking at things differently and asking different questions as you're observing your data. It was late in the game before we realized that was something we were interested in. And then finally, our total patient encounters. So as we broke this information down, it was really encouraging to go from February, March, April, and May and see that for referrals, enrollments, encounters, everything was trending up. So we were using this data in a way to kind of motivate us and see and observe if we were moving a trend in the appropriate way. At face value, you could look at things like our patients decline column, right? You don't want to see more patients declining to come to your centers, but we also used that as kind of an encouraging mark because that meant we were getting more referrals and therefore more people had the opportunity to say no. We at least knew we were casting a wide net with this data going forward. So let's move to the next slide and I'll just show you a final example of how you can use data in your centers, and it doesn't have to be fancy. So these are reports that we render every month in our centers where we look at net encounters in our phase 1 program, that's the graph on the left, and net encounters in our phase 2 program, that's the graph on the right. And why I show this to you is because what we found from months, even years of collecting this data is whenever I see a jump in phase 1 net encounters. So for example, September of 2020, you can see there we had a big boost in our phase 1 encounters. That meant more procedures through the door, more people on the floor. We know that there's going to be a downstream impact in our phase 2 operations. So we track that data, and as I see our trends going up in phase 1, I prepare and talk to our phase 2 staff to let them know that more referrals are going to be coming in. They should expect that within a couple weeks that we're going to have more people enrolling, classes are going to get busier, and there's kind of that slow rollout where we really see that evidence play. So this is just a way of showing you that really basic information can allow you to make some changes and prepare for change if you use the data regularly. But again, this report, I print this off of my EMR and I throw it into a spreadsheet and I visualize it. It takes me maybe 5-10 minutes at the end of the month. It's not too fancy, but it really has a big impact for our centers in particular. And I think that kind of takes it up for what I had to prepare. I think we're down to questions, Steve.
Yes, it does. And thank you very much, Professor Grace, Matt, for your insights. I think that it's provoked a number of thoughts, hopefully, in terms of what you might be doing that you haven't been doing so far. And what we'd like you to do, just so we can get a sense for what some of those things are, is in the chat box, just type in one insight from today's training that you're going to use to help you better work with your program's data. And we'll look at some of those, ask our panelists to respond to those. But if you can share one insight, something that, caught your attention, something that is making you think of something that you could do differently, do better. If you can enter those in the chat, we will take a look at some of what those are. All right, as they start to come in, and I realize it takes a few minutes to compose a thought and then to type it into chat. A comment from Jeremy Leggett about reaching out to physicians accrediting bodies and finding out if cardiac rehab, pulmonary rehab is required to be ordered, and also following up on data for tracking referrals. Matt, how long has it been in your program since you started tracking the number of referrals that you were getting from all of your sources?
Well, we've probably been, at least on our current referral process, for about a year. So we made a change in our EMR from Meditech to Epic. And that was kind of the benchmark timeline where we really started looking at things differently. So we're just over a year on that. But I would say to that comment too, and one thing that surprised me as I started getting more acquainted with how the service lines operate, a lot of providers, depending on how their group operates, they set benchmarks for themselves within the provider group that they try to keep themselves accountable to every year. And they're always looking for attainable but quality initiatives like that kind of that PAD management goal that I described. So I think that's a great point Jeremy makes, is reach out to your providers and see what they're doing. You may have a goal that would help your department be able to track it, and it would help them too.
And the beauty of these registries too is they benchmark, so they will show you comparison data to other centers, and maybe you can use that to motivate them and say, hey, you know what, I bet you we can do just as well as these other hospitals. Like, if we work together, let's try and do this together. But I know the surgical NCDR registry does the same. Like, all of them actually now, because of evidence, have that referral there. When we looked at kind of we looked at about, I don't know, 12 units across Ontario, and not American data, but we were looking at referrals and enrollments, depending, did they just have automatic referral? Did they have automatic referral with care coordination? And we, with the units with the best practices, got up to 80% referrals. So not, as I said, there's always some exclusions, and 75% enrollment. So just something to think about, but obviously you're not going to start there. And that, again, that was just the best performing centers. Yeah.
All right, thanks. And then there's several comments in here about provider specific referrals as being something that they haven't necessarily been doing, but that they see the value of. Would either of you care to share like something that you've learned as a result of, after you began tracking and looking at your provider specific referrals, just to reinforce that, because I do think that that's an important thing to be looking at.
Yeah, I think if you have a good relationship with the inpatient providers and you get to know them, and like, for example, on our team, someone will go up to one of the providers and say, hey, this is the chart of a patient, and actually this patient to us looks like something that we could really help. I'm just curious, was there a reason? Did the patient say something to you? And then you kind of start to get, you don't want to be accusatory, right? You want to get people on board. But I think it's an educational opportunity for the provider to learn, what you can do there, what kind of patients you can take. And then you see over time, some of them, you can't change their mind, but some of them really, you develop that relationship, and it makes all the difference. Matt, did you have any examples or?
Yeah, there's nothing wrong, in my opinion, in a respectful and healthy way of formulating a little bit of competition among your providers. Every once in a while, if I notice that there's a dip or I see a trend, I will just put a generic chart up. So we have a lot of providers, but we have about 14 interventionalists. So some months ago, I put a little chart up that showed 1 through 14. I didn't name any names and call everybody out, but it showed a difference that we had referral rates of really high in the 50-60%, and some very low in the 3-4%. And that was enough for everyone to kind of realize what they were doing, where they were referring, and seeing what their peers were doing. And like you said, with the relationship, you are going to identify who your provider champions are. And they might even be nurse practitioners that or advanced practicing nurses that are able to spur a little fire under your main providers. But when you find them, show them that data. They'll help you out. Yeah, absolutely.
Yeah, and as we continue this conversation, if you have additional questions that you'd like to ask our panelists, by all means type those in, and we'll try to answer the ones that we can now, or follow up on the ones that we can't. A number of comments from people about how they can better leverage data coming from registries, coming from other sources, and my thought on that is, and I'd like the panelists to respond, that that data is going to be useful, but there's still going to be an element of data that you're going to need to collect and work on yourselves as well. So has that been your experience? And what are some of the things that it's taken your own data, looking at it yourself, even collecting it into your own spreadsheet, to get something that you thought was really important for your program?
Yeah, I would say, administrative data, it's collected for a different purpose too. So it's not going to answer everything that you need to, but I think it really does give you the population. It really helps you get your denominator. And I think you can often use it for your numerator too. But Steve, to your point, you often have to do a bit of extra there. And the other piece is it's the continuum of care. So often they measure something, just part of the process, the referral, and then you need to link that and follow those patients. So again, it's that data capture plan. So you do need something that's across the continuum. And I don't think all the registries are linked, but again, it's I think there's some really good ideas around that in the implementation plan guide. And it's just start small and do what you can, and use those to the best of your ability. But Matt, what would you add?
Well, I would echo those same sentiments, and um, on top of that, when I look at those major data points from our registries, they always tend to make me ask more questions of, why is that the percentage? And so those are really the variables I use to help me drill down. And it would be exhaustive if our registries, 'cause I'm sure they're the same way, they want to know, well, okay, here's your number of referrals. Well, how many providers, and how many from inside and outside, and how many were these diagnoses, etc. You've got to make your own reports to be able to find that and really highlight those demographics.
Yeah, it's too bad. I think some of the EMRs are not great with outpatient care. Like they're so directed to inpatient. So, but again, that implementation guide has some really nice reports set up, and a spreadsheet column headers, and that I think give a great launching point for everyone. So you're not reinventing the wheel. And yeah.
All right, thanks. I am sensitive to time, and so if we can move to the next slide, and the question is, what comes next? And I think that the data, it's everyone's responsibility, it's everyone's opportunity, because this is just another way that you can learn about how to better serve your patients. So looking at these action steps, you should continue working with your team to establish baseline data, adding tasks, and setting targets. And sometimes you set targets and you can't quite meet them, and that's fine. But if you don't set them, you'll never meet them. So it's a good supporting mechanism, prodding mechanism to help you move along. In terms of exploring, there have been a number of references to the Module 4 implementation guide. That'll be sent out to all of the partner hospitals in the next day or two. We send it out with the slides from today's event, and we really want to encourage you to look at that one. There are a lot of examples in it, a lot of very tangible, practical advice on how to do things. And I think that one of the most important messages that came across today is you can make data very complex, but you don't have to, especially at the start. So if you start off with some things that are very basic and answer some questions that are really basic but really important, that'll get you started, and then you can move along and go from there. And then we want to encourage you to discuss your progress, your challenges, questions that we weren't able to address today in your upcoming peer action groups, and those are scheduled for the next week or so. So we want to encourage you all to participate in those as well. Looking ahead, next month is an absolutely critical training module focused on the nuts and bolts of getting started with automatic referral. And that's a little bit earlier in the month. It's August 19th, so make a note of that. It should be an excellent opportunity to learn about how to get that process started. It's critical, and we're excited about what we have to share with you next month as well. Having said that, we want to encourage you to provide us with some feedback on today's event. So as we wrap up, there's some feedback questions that will pop up that we really appreciate your answers to. I want to thank again Professor Grace and Matt Thomas for your insights today. It's been great, and thank everyone for their time this afternoon, and we look forward to talking with you all in peer action groups in the next couple of months or next couple of weeks, and then the next training module on August 19th. So thanks everyone very much, and have an excellent rest of your day.
Thank you.
Thank you.